Next, I'd like to welcome Dr. Blanca Piazuelo. Dr. Piazuelo is a research pathologist at Vanderbilt University Medical Center. Her main research interest is in the precancerous process of human stomach, primarily caused by Helicobacter pylori infection. She is the Associate Director of Tissue Morphology Subcorps of the Vanderbilt Digestive Diseases Research Center. And Dr. Piazuelo serves on multiple projects related to inflammation and carcinogenesis of gastrointestinal tract in humans and animal models.
Thank you so much for the kind introduction, and thank you to Juha and Robert for inviting me one more time. I am amazed at all the cutting-edge science that I have seen during these 2 days, and I'm going to take you back to basic pathology. So many of you have seen this presentation. There is no newer data. Probably we have enough numbers and data to digest. So now enjoy just the images. So my outline, I'm not gonna talk about the chorea cascade because you already know very well about that. I'm gonna talk a little bit about subtypes of intestinal metaplasia, staging systems that include intestinal metaplasia, which are OLGA and OLGIM, and this is a concept that, for much that I repeat, some people don't understand, and some caveats about these systems. So this is the chorea cascade. These three that are marked here in red are precancerous lesions. This is a process that takes decades to get to cancer. And one thing that I wanted to emphasize is what is gastric atrophy. When you read a paper about gastric atrophy, you have to ask yourself, what is the investigator talking about? Atrophy without metaplasia or atrophy in the big spectrum, including all the variants of atrophy. So gastric atrophy is defined as the loss of native epithelium, whether replaced or not by other type of mature epithelium. So atrophic gastritis without intestinal metaplasia or with intestinal metaplasia, that is atrophy. So these are related terms. Multifocal atrophic gastritis is the term that I like because actually it's multifocal, but is synonymous could be atrophic gastritis. And when you don't have the inflammatory component, we call it gastric atrophy. So these are the variants. These are variants that can be seen in an atrophic stomach, can be non-metaplastic, which is loss of glands only, intestinal metaplasia, or pseudopleurotic metaplasia. And one thing that I wanted to comment is that this is not one or the other, because in most cases, all of these can be mixed even in the same biopsy. So I've shown this before. We have two images of corpus, normal corpus and normal antrum, just to show you what it means. Atrophy without metaplasia is just loss of glands, so the glands can be diminished or shrink, fewer in quantity or smaller in size. And in this one is a case of antral atrophy, in which you can see only few glands remaining. These are two examples of intestinal metaplasia, antrum and corpus, and one type of metaplasia that is only in the oxyntic mucosa is the pseudopleurotic metaplasia, in which you can lose all the parietal and chief cells, and the glands may resemble the antral glands. So that's pseudopleurotic metaplasia. All of these are the spectrum of gastric atrophy. So subtypes, there is multiple classification systems, but the one that is most commonly used is the complete versus incomplete, because this is very simple. In the complete type, you can see well-developed goblet cells, which are separated by enterocytes with brush border. And at the bottom of the crypts, you see Paneth cells. And this is a very important component that I don't want people to forget when they are classifying intestinal metaplasia. Because I think Paneth cells, for some reason, or at least in what I've seen, they keep like the bottom of the crypt organized. When you see Paneth cells, you don't see irregular or disorganized nuclei. This is an example of a gland with incomplete type, where you see goblet cells that may be in different stages of differentiation, and these intermediate cells, columnar cells with mucin droplets. Usually you don't see brush border. There may be an occasional Paneth cell, but that doesn't mean it's complete. So this is important because the incomplete is the type that is associated with progression to cancer. This is another example of complete-incomplete, which is with lower magnification, and this is to show the architecture of the crypts, because this is important also for the classification. In the complete type, usually you see these straight or slightly curved crypts, while in the incomplete, you can see irregular glands, even branching, like in this case. I wanted to show you this because it is not always complete or incomplete. Most of the times when you see incomplete, it's a mixture of both. So in this case, I wanted to show you what is the normal gastric. Here you can see normal gastric glands. And I'm separating with this line all the area with intestinal metaplasia. You can see here a reminder of the gastric, also normal epithelium. So you see that this looks like incomplete, this is incomplete, this is another complete, and so on. At the bottom of here, you see Paneth cells, but not here so much. So this is mixed, complete and incomplete, which is most common, that only incomplete. Now, this is just a magnification of the same thing, just to emphasize the complete versus incomplete, that it seems each crypt is doing their own, responding to different signals or responding differently to the signals. Most of the times with a good H&E, you can make the classification. But in cases that may be needed, not in this case, obviously, but it's just to show you the staining, the ABE-PAS is a good staining for differentiating metaplasia from non-metaplasia and for subtyping metaplasia. So this is a case of complete metaplasia with Alcian blue PAS, and the pink stains normal gastric epithelium, and here you can see some areas of complete metaplasia in which the goblet cells have blue staining, which means mucin, intestinal mucins. So this is only intestinal mucins in goblet cells, and the intermediate cells should not have any mucins because these are enterocytes. So I like this example because it shows the multifocal nature of the process. Yesterday we saw beautiful images of endoscopy, and in which somebody, I don't remember if it was Fabian, that showed the multifocal process of the nature of the process. So this is complete metaplasia. And this is a case of incomplete, in which you see here is an area of normal gastric epithelium, which should stain pink. And here is a mixture of intestinal mucins, which are stained blue, and gastric mucins, which are stained pink. This is one entire biopsy replaced by intestinal metaplasia. And here you can appreciate that when you have very extensive metaplasia, it's usually mixed. So we can see some areas that look like complete, another incomplete, and so on. And this is just a magnification of this area. In the middle, there is one gland that is incomplete and is surrounded by complete metaplasia. So we know that intestinal metaplasia subtyping now is useful for gastric cancer stratification. But one thing, because intestinal metaplasia is a very heterogeneous lesion, and most importantly, most patients without metaplasia will never have cancer. So that's why it is so important, the subtyping. We know that the incomplete type, sometimes we call incomplete, but incomplete usually is a mixture of complete and incomplete. So you can call it mixed or you can call it incomplete, and anyway, the risk is going to be the same. And this type is associated with the higher risk of cancer. So about the systems, OLGA and OLGIM, it is known that, I just want to emphasize that the intestinal metaplasia extent is part of both systems. So it is known that the extent of atrophy correlates with gastric cancer risk, and these systems are useful for the classification of the risk, and is supported by a big number. I think I'm missing the last ones here, but this is regained. But many guidelines support the systems. So for both systems, 5 biopsies are required. 2 from antrum, 1 in caesura. This is the updated Sydney system. These 3 should be in one jar, corpus in a different jar. And the OLGA system includes all histological variants of atrophy. As I mentioned already, non-metaplastic atrophy, intestinal metaplasia or pseudopyloric metaplasia. So it's like the extent of all these variants together. The stages are 0 to 2 low risk, 3, 4 high risk. And then an atrophy score is calculated for the antrum, for the corpus, and then is brought to this table. I'm going to show you how to score actually the OLGA. This is OLGA, but OLGIM is very similar. This is a very pretty, this publication shows a tutorial that shows the pathologists how to do it step by step. And this is one of the figures that I like them very much. So each biopsy is represented by one of these rows. So we have 3 biopsies of antrum and 2 from corpus. And here are 10 glands. The yellow glands means atrophy, antral glands. So the ones that are replaced by blue epithelium, those are intestinal metaplasia. So for example, for this biopsy, we have 2, so it's 20% atrophy, you would say. In this one, we also have atrophic glands. So this gland is shorter or may have disappeared. So this is also considered atrophy and is counted among the score. So for this biopsy, it would be 30% and so on. So we then make an average of these 3, 20, 30, and 30, and we come up with this. And this gives a score of 2 in this table. The same for the corpus. Each biopsy should be scored separately, and then an average is calculated, and then a score is given according to the average percentage of either atrophy or metaplasia. And then if you have a score 2 in the antrum and score 1 in the corpus, you go to this table and you find here the stage. So the OLGIM system is the same, but only assessing intestinal metaplasia. So you can use the same visual score scale, but it's just only metaplasia, ignores totally the other atrophy. Yeah, and I'm going to show you in one single biopsy what is the difference between OLGA and OLGIM. So in this biopsy, this is all atrophic because you don't see any glands here. Maybe there's a little very atrophic here. And here are 2 areas of intestinal metaplasia. So if we were going to calculate the OLGIM, only metaplasia, you could say that is 30% of metaplasia in this biopsy. But if you are going to calculate the percentage of OLGA, you have to include the metaplasia plus all the other areas of atrophy. So you could say that this is a 90%. So this is an important concept that OLGA cannot be lower than an OLGIM state. And I have emphasized this several times, but you see lots of published papers when they do OLGA separately, OLGIM, and then you realize that OLGA is lower, and that's not possible. So if it's done that way, this doesn't work. It's not. So caveats. One of the technical considerations for OLGA, if you're going to do the atrophy, you need to see the entire thickness of the mucosa. Rarely, I don't know how other pathologists feel about that, but I have rarely seen biopsies that are like this thick and well-oriented, except for the research biopsies that we get from other places. But usually the biopsies are very small and are not well-oriented. So for OLGA, you need the entire thickness of the mucosa, and also because the OLGIM has better inter-observer agreement because it's a much easier diagnosis, OLGIM may be preferred for clinical practice. One important thing to comment about is that in both systems, OLGA and OLGIM, you can have a score of 3 in the antrum and no atrophy in the corpus or no metaplasia in the corpus, and still you're at high risk. So this is an important concept because somebody mentioned that yesterday, that sometimes you can have the entire corpus with atrophy and still they don't consider that in many guidelines as extensive. And I disagree with that. You cannot say that extensive is only when it's in the corpus or when you have a corpus and antrum, because you can have a little area here and there, and that doesn't mean the same. So this is a very important caveat when you do the systems. And this is another example that I have shown before. You can have intestinal metaplasia in all biopsies and still be a low risk, which doesn't make sense. So all the all these systems are good, but they have to be interpreted in an individual basis. For example, in this case, if we have 3 antral biopsies here, and all of them have 60% metaplasia, this is a hypothetical example. This 60% will be still a score of 2. And if you have also in the corpus, like mild 30%, you will still have 1. And when you go to that, this table, you will get a stage 2. So this obviously cannot be a low-risk patient. So each patient should be individualized. And I think Nolo was saying that they are following also the stage 2 because of these reasons. My last 2 slides, I'm going to talk about a new initiative to make the pathologist's life easier, and your lives too, because I have heard many of you that as soon as you're pathologist, you go to pathologist, oh, do this OLGIM, they run away. They don't want to know anything about you or the scoring OLGIM or subtyping intestinal metaplasia. So, and I understand that they may be too busy for that. So one way would be to solve the problem, diagnosing and grading atrophic lesions using machine learning for image analysis. So this is just an example of some recent papers about that. And our idea, we have, of course, Constanza is the promoter of everything, but Constanza and I are leading a project about grading, doing OLGIM system and subtyping intestinal metaplasia using machine learning for this analysis of these images. So this was an initiative discussed during the think tank and NCI with the pathologists Kay Washington and Robert Genta. And the idea would be to do the OLGIM and subtyping of metaplasia using the images. So we will need for that H&E and Alcian Blue Pass. And the ultimate goal is to build a free platform for pathologists. This is in the ideal world. Any pathologist around the world could scan the images and upload it in the platform and get an initial scoring or classification of metaplasia. So the coordination, the institutions that are coordinated are NCI and Vanderbilt, and there are several groups that have already expressed their interest in collaborating, such as Stanford, Kaiser, and UAB, and also groups from Chile and Latvia. And this is also open to collaboration, so whoever wants to collaborate with us, just let us know. And take-home messages. Intestinal metaplasia is one of the manifestations of gastric atrophy and not a different diagnosis. OLGA evaluates intestinal metaplasia, pseudopyloric metaplasia, and atrophy without metaplasia. And OLGIM only evaluates intestinal metaplasia. The quality of the biopsies, I didn't mention this too much because of the time, but now that I see that I have a few seconds, the quality of the biopsies and the histotechnology, the way the histotechnologies embed the biopsies and orient the biopsies are critical determinants for a pathology report. The extent of atrophy and subtype of metaplasia should be incorporated into the clinical management. And finally, computer-assisted resources for assessment of intestinal metaplasia will help the work of pathologists. So with that, I'm done. Thank you so much.